Ladies and gentlemen, welcome back to our international ground rounds. I'm very pleased today to have a special guest. It's a mentor, it's an entrepreneur, it's a leader. He's a past president of the International Federation of Facial Plastic Surgery, past president of the European Academy of Facial Plastic Surgery, is a board member of one of the foundation from the Italian Academy of Rhinology, and co-founder and past president of the Italian Academy of Facial Plastic Surgery, and former member and president council of the European Confederation of Otolaryngology and Head and Neck Surgery. I'm very glad to introduce Professor Pietro Palma. Good morning, Professor.
Good morning.
So today's topic, it's a very new to me, and I think that everyone should understand the importance of the new generation and how the challenges will impact our field and our mentality. And today's topic from Professor Pietro Palma is going to be exactly on ethnicity and the differences in the challenges for the future. So briefly summarizing, Pietro Palma is going to have a brief presentation in about 25-30 minutes in which he will do a glance in this new generation of differences and how can we challenge those things in rhinoplasty. So if anyone would like to address some questions, as usual, you're pleased to type your question and we will answer them at the end of the talk. So, Professor Pietro Palma, I'm very glad to have you here, and please share your presentation.
Here we are. Let's do it again.
Yes. So can you share it again? So the title of the presentation is Ethnic versus Global, Changing Rhinoplasty Trends in Z Generation. That's a very important topic.
It is written, screen sharing has failed to start. Please try again later.
You as a co-host, could you try once again?
Yes, I'm doing it. Always the same issue.
Always the same. Would you please take an exit from the meeting and try once again? That's some issue. Yeah, exactly. So this is in the meantime, we are having some issues with the sharing. So I would request Professor Pietro Palma to take out from the meeting and access again. So the importance of this topic is because of this, not only from the pandemic, but the fact that there are differences in the ethnicity will affect our field. So Professor Pietro Palma is back at it again. I will request him to be a co-host once again. Yes. Let's try for your sharing now.
Doing it.
Yes. Because at the previous attempt, it seems that was working exactly. Perfect. Thank you so much.
Fine. Actually,
yes, fine.
Here we are. Dear friends, dear colleagues, it is a pleasure for me spending a little time of this Sunday afternoon here in Italy with you. Now, this is the title of my presentation, Ethnic versus Global, Changing Trends in the Web 2.0 Rhinoplasty Generation. And I included the millennials and the Generation Z. This is my brand. I work in Milan, Italy. And my practice is actually 100% aesthetic rhinoplasty. I don't do anything else. But before inviting you to my table, I would like to listen to my 30 minutes story. I would like to say thanks and grazie to Dr. Puya Dehgani for having me here. And I think that he did a great job during the past month in organizing this kind of webinars. So the first question is, are rhinoplasty trends changing in the Web2 rhinoplasty generation? And the second question is, if the answer is yes, is it the time for changing the paradigms of what we do? I will not, let's say, be boring with you to explain who millennials are and who Generation Z are. Just a little table here. Millennials are the one born between 1981 and 1996. And the Generation Z or Zoomers are the ones born between 1907 and 2012. Why these are important? From the demographic point of view, 82% of my patients belong to both these two categories.
Amy, it says you are trained in technology. That's very good. Are you adept at Excel?
No,
PowerPoint.
no.
Exactly in what area of technology are you proficient?
Snapchat, Pinterest, Instagram, Vine, Twitter.
I'm surprised you didn't say Facebook.
That's for old people, like my parents.
Well, this is the people that we are dealing most of the time. I would like to say thanks and grazie to my patients, actually, to my patients of this range of age, because I learn from them and I continue learning from them. What I've seen over the years is that patients' requests and tastes changed a lot. And why? Because beauty trends change over the years. And we learn from them and why requests and tastes change. Because we have to understand and to answer this question, who are the trend setter of beauty? For sure, not us, the surgeons. In the time of Instagram, in the time of Facebook, in the time of the web, in the time of fashion, other set the trends. An interesting question for you. Do you know which is the most visited website by girls? This is. It is here. Victoria's Secret. I asked my international friends to make a little international survey about aesthetics of the nasal tip. Today, I will concentrate mainly on aesthetics of the nasal tip, which is the most important topic from this perspective. I asked to my Korean friends, and they sent me the most known beautiful girls in Korea. I asked for my friend from Thailand, from Colombia, from Brazil. And these are the beauties in their countries. If you look at the face, of course, all of them are different, but what do they have in common? Look at the tip. Softer tips is the trend. You see that they do not have sharp tips, they do not have very structured tip. From my personal experience is about international patients represent 28% of my rhinoplasty only practice, is that we are really moving towards a global unified facial vision of beauty. And the answer to this question is yes. So the patients that I see, they think more global and less ethnic. And the contemporary tip, if you look at this picture, is softer and rounder compared to what I was doing, for instance, 15 years ago, or even 10 years ago. So we have to focus on the perspective of the Web 2.0 generation. And at this point, I would like to put some spicy drops in our Sunday soup. I think that when I go to meetings, I see that many of my colleagues, maybe I would say most of them, they tend to apply old paradigms, thinking that the BiTip, the white dot here, the white dot, the light dot here, is the gold standard. But look at Natalia Vodyanova, an icon of contemporary beauty. Do you see any BiTip? Look at Irina Shayk. We don't see any BiTip. Look at Monica Bellucci, an icon of Italian beauty. We do not see any BiTip. So my vision, I am really convinced that the narrow BiTip has become a thing of the past. And that contemporary tip is softer and rounder. So if we go to the question, contemporary tip aesthetics, does it exist such a thing? My answer is yes. And then the second, of course, consequent question is, should I rethink my way of doing? And the answer again is yes. So I would like to give you 3 pearls of wisdom. The first one is that I changed the way I analyze. It's different. It's totally different than what I was doing in the last years. And I understood actually that the true essence of rhinoplasty is not making again a new nose, rebuilding a new nose every time. But the true essence is all about the power of light here, the power of light. Let's keep it simple. This is a face of a woman. And you see that here, if we play with the white and black, we see that there is a light shade, light interplay, light, shade, light again. And if we go to the tip, I see 4 aesthetic tip subunits. The number 1, we see the central light. So not the BiTip, not the 2 dots, is the central light. And what I see is the lateral light. And then I see the supracrural shade. And then here I see the scroll shade. So what I aim to create is creating, and they are different in every face, in every nose, these aesthetically beautiful tip aesthetic subunits. 1, 2, 3, and 4. And the second pearl of wisdom, again, 2 spicy drops again in this supper soup. My perspective is that aesthetic rhinoplasty is not a structural operation. So I do not think to rebuild every time a new nose. For me, routine use of open destructuring and consequent structural rebuilding is just overkilling in most of the cases. What I have developed in the past years is considering aesthetic rhinoplasty a surface operation. Because I want to get a surface balance, an aesthetically pleasing surface balance between light and shade, light and shade. So, what I mean, I aim to sculpt only those structural elements responsible of the eye disturbing nose surface problems. So I focus exactly on those structural elements that I don't like, without, let's say, making approaches or let's say extension of them that may put a challenge to the nose. So I developed the endonasal multiportal approach. So we have, and I like actually the endonasal approach because it allows me to be versatile. I don't use the same incision, the same approach to treat different anatomies. So the multiportal approach, the principles are several mini incisions, endonasal incisions. By doing this, I do minimize dissection and I do minimize the amount of excisions. Well, actually, in my personal evolution, where am I now? For me, compared to what I was doing years ago, I am at the next level. I am beyond the dichotomy open versus closed approach. I am at the endonasal hybrid rhinoplasty. What does it mean? It means incorporating sutures and the grafting techniques into the endonasal root. These allowed me to rediscover the many virtues of endonasal surgery, which is a near bloodless surgery, minimal tissue plane distortion, modest scarring, early healing, preservation of normal structure and support, safety. It is safer, much safer, and ease of revision if necessary. And which are the endonasal doors? You have many of them. You can get everywhere you want. I like the transcartilaginous extended, we will see it afterwards, the infracartilaginous, the delivery approach, the tailor-made. I will show an interesting case, a clip of an interesting case where I changed the incisions on the two sides. On one side is a kind of incision, on the other side is a different incision, just because anatomy is different. And then the endoscopic approach. For instance, when we have to, let's say, giving the impression of, let's say, of correcting a twisted cartilaginous part, the endoscopic approach is an elegant way both to sculpt the cartilage and then to use it as a spreader graft. So you go there, you go up, and then you go with and through suture. So to keep the graft into the right position. And which are the choice criteria for my endonasal approaches? We all know that the tip has mainly 4 intrinsic parameters. They are volume, definition, width, and symmetry. So, and they are different in every patient. So these four parameters of the aesthetics of the tip dictates my choice. Well, for instance, when I want, which is in most of the cases, I want to correct the volume and the definition, I go to the transcartilaginous extended. If I want to also to correct the width, maybe I can add the intracartilaginous approach. And when I want to correct pretty asymmetrical tip, I use the delivery approach. And really, I love, this is what I do in most of my cases, the transcartilaginous approach. This is a very precise and elegant approach that allows at the same time to approach the tip cartilages as well as the dorsum. This is important to leave enough structure of the remaining caudal lateral crura. And you see that through this way, I am just already dissecting the dorsum. And it also allows me to correct the supratip fullness, to remove the soft tissues of the supratip under visual control. Precise dissection. And I always like to leave on the top of the cartilage. This is exactly sculpting the scroll area. Here it is refining the scroll area. Sometimes asymmetric tip, you need asymmetric doors. For me, this is clear. Why should I use the same incisions and the same approach for the two halves, which are completely different? In this part, on the left part, I have to correct the volume. So correcting the volume, the transcartilaginous approach works perfect. Here in this part is different. There is an asymmetry, there is a concavity here. So I have to expose more the skeleton of the right tip. So delivery on the right side, transcartilaginous approach on the left side. This is also the side view. I don't like, for instance, in this case, the relationship between the projection of the radix here and the projection of the nasal tip. And these are really refinement. This is a kind of a finesse rhinoplasty. So here there is the transcartilaginous approach on the left side, over there. And here there is the delivery approach on the right side. Remember, here there is a concavity. So I have done the intracartilaginous incision. I leave a pedicle here. And then I put here just to correct the convexity on that area. And I fix it with suture. Generally, I like to, let's say, to shave the dome. And here I use the contralateral excision just to correct the further element of the concavity. So this is pre and post. Here there was this convexity on the left side, concavity on the right side. This is much better there and there, much more symmetrical tip. Also the nostrils, we got more symmetry. This is the side view. The tip has been pushed back and the radix has been moved upwards. These, in my eyes, create a better relationship between the nasal length and the projection of the nasal tip. Again, here you see, in many of my cases, I also release the depressor septi muscle here. The 3/4 view, the other side view. Columella was absent here. In this part, you use a little graft, a plumping graft, and you recreate a much better relationship between the upper lip and the columella. This is the 3/4 view. And the third pearl of wisdom is that I changed my technical tools. So changing the way I analyze, the way I approach, the way I do. And what I do more transcartilaginous extended. Transcartilaginous extended means that you sculpt the tip via transcartilaginous approach, and then you add something by using, for instance, the hemitransfixion incision. If you want to put a shield, or if you want to put a plumping graft, or you use the infracartilaginous approach, a little infracartilaginous approach, if you want to correct the caudal, for instance, the caudal margin of the lateral crest. I use less domal sutures because I understood they are not benign procedures. In the long term, especially in thin skin, you get buckling, you get bosse, And you get also an inversion of the curvature of the lateral crus. I do much more interdomal and subdomal sutures. I like to shape in order to create that shadow at the scroll area. And I like to sculpt the lateral crura. I will show you afterwards a clip on how to change the curvature of the lateral crus by sculpting them. And one of the most important elements that I have introduced in my surgical practice is the use of micrografting, especially the cartilage paste. I don't use almost any more columella struts. I use very frequently the tongue groove, and compared to a few years ago, I do some more dome divisions. This is the strategy. Let's go and look at the results. And my goal actually is always reconstitute normality as closer as the nature did. Nature didn't put strong buttons. Nature didn't put long spreader grafts. Nature didn't put extended septal extension grafts. I try to go as closer as possible to the natural shape and the natural form. And here there are the cases. This is the first one. Well, look here, this is a twisted nose. There is a bulky tip, convexity, and a concavity here. I always take special attention to the scroll area here. The scroll area is the junction between the upper laterals and the lower laterals. Look how it is different. When you have a twisted nose, you have always a constant element, what I call the hidden ala. You see one part of the ala is hidden. You see much more on the other side, less on the other side. This is a stigmata present in 100% of the cases. She wanted, of course, she is a tiny girl, and she wanted, let's say, a slight concavity of the dorsum, and of course, a shortening. The columella is hanging. Now, let's think about in terms of lights and shadows. I have to recreate the brow dome lines or the dorsal lines. I have to reduce the amount of light over the nasal tip, isn't it? This is just that. We don't need anything else. So this is the pre-op, and you see how are the brow dome lines. Look the alar columellar relationship. Look at the relationship between the ala and the cheek. Transcartilaginous extended. So I used some grafting here. Excision. So when you see light, it means convexity, isn't it? So convexity, it means that you have to shave it, shaving. I see a little convexity over here, shaving here. Here there is a concavity, so you add something else here. So in this part, I added a little through a small infracartilaginous incision. I added here a little rim graft. And of course, look at the bony lateral wall, how different is on the left side compared to the right side. Of course, here you need to do double osteotomy, and here you need to do one single osteotomy. And of course, septal work is paramount because we want to align, especially the cartilaginous pyramid. This is the pre and post. We recreate the new brow dome line. We reshape the nasal tip. Better symmetry of the alar columellar relationship here. We do not see anymore the hidden ala. The ala is almost at the same level. And again, pre and post, lights and shades. Nothing less, nothing more. do you really need to rebuild a new nose and to use 4 or 5 hours of your time to rebuild this kind of nose? So look at the alar cheek junction here and there, pre and post. Look at the brow dome lines. Look at the hidden nail. The side view, the other side view, the base view. The septum here is paramount. The nasal spine, you see the nasal spine is there. So you have to correct the septum and the basement of the septum, which is the nasal spine. And you see that here I put this little frame graft, giving more symmetry with the control lateral side. This is the 3/4 view. This is a young man, handsome boy, tall. Well, actually, she told me, doctor, what I don't like is this hump, and especially this junction here. But don't give me a female nose. I want to keep my masculine features, and especially on the frontal view, don't make me a narrow nose. Just refine it. Transcartilaginous approach again. Why? Because the nasal tip, what I want to change is just a little bit of the tip volume. I do not want to make a fancy tip, a strange tip. Transcartilaginous approach. Refining the nasal tip, refining the scroll area. You see, there is more shadow here. Recreating the brow dome lines. Okay, look how powerful are the double osteotomies in recreating symmetrical lateral walls and more definition of the upper part of the nose. You see it here, refining of the tip and the new brow dome lines. Again, wide, more narrow, while maintaining a strong dorsal line. And this is the side view, a little shortening of the columella here, but maintaining a straight profile line. Again, the muscles, the 3/4 view, strong profile, the other side view, strong straight profile line, 3/4 view, and the other 3/4 view. Look here. When I was telling you the supracrural shade, I like this, the supracrural shade. And here it is, let's say, I was able to recreate definition in this area. These are, in my view, difficult cases because you have to deal with thick skin, soft tissue envelope. Again, look at the scroll area here and there. It is wide, it is, let's say, fullness, and it is asymmetrical. Also here there is let's say, an excess of tip volume, and here there is also a lack of definition of the nasal tip. Again, transcartilaginous approach, and I use the technique of flattening the lateral cross that I will show you afterwards. The pre and post. In these cases, when I have this kind of freely underdefined nasal tip, at the end of the operation, I do a little domal infracartilaginous incision, and I put an onlay graft over the nasal tip. You see that here, well, actually, this is a little bit asymmetrical here, but it gives definition, and at the same time, it gives projection to the nasal tip. Because in these cases, in the long term, in cases with thick skin, generally, you lose projection. So you need also to think in terms of future of long-term results. You see here, one and there. This is actually the tip graft, the peck graft, the onlay graft, the butterfly graft. You call it as you like. But the aim is giving projection and giving definition to the nasal tip. And this is the three-quarters view. The radix, you look the distance between the corneal plane and the radix and the nasum. It is less. So the nose looks smaller, less long. When she's smiling again, I reduce the nasal tip and I release the muscles here. The three-quarters view, the new brow tip line, more definition. We don't see the fullness here. That fullness is not the tip. That fullness is the scroll area. And I like to shave it, the scroll area, to recreate more definition of that area. This is the other three-quarters view. Here. This is a technique actually that I have seen many, many years ago, maybe 20 years ago in the States, when I was a young doctor willing to expand his skills. So how to correct the overlay convex lateral crura? They are always asymmetrical. And this is also a kind of malposition of the lateral crus. You see that it goes upwards, doesn't go lateral. When you get actually the malposition of the lateral crus is a syndrome because it is composed of several features. You have an excess of tip volume, you have a thin ala, and you have a huge facet, the soft triangle here. It is huge. So the combination of these three elements creates the feature of the lateral crura malposition. So my idea was, why not using what we do for septal cartilage, which is actually stronger than the lateral crus, just making partial thickness incision on the vestibular side, just to carve and just to shave the convex part here. And always listen to what the patient wants. Doctor, please reduce the size of my tip and give me a softer tip, a natural tip. This is the lateral crura malposition, which is another flower of the month. In the last 2 or 3 years, a lot of papers, a lot of presentation at meetings. For me, the question is about flattening the lateral crus. Transcartilaginous approach, and I just remove a little tiny piece. I leave a good part of the cartilage is there. Then what I do a, let's say, a kind of dissection of the vestibular skin, and I expose the vestibular side of the lateral crus. I elevate the vestibular skin here, and then I do this kind of retrograde, the transvestibular flattening of the lateral crura. I am dissecting the vestibular skin, the two single hooks. The most difficult part is analysis. You have to decide before making this incision where exactly in which site you have to do this excision. And the number and the thickness of this excision, it depends. You see here, it was bulky, it is flatter now. And where and how thick and how deep you have to go with your thickness. So diagnosis is essential because the thickness of the cartilage, how strong they are is different from case two case. And here, the pre and post, you see here, no bulky tip, much more symmetrical. And of course, we have a better relationship between the width of the bridge and the width of the tip. Puya, you tell me when I have to finish. Huh? Okay. Smiling view, the base view, base radix view. Look at the aesthetical relationship between the width of the dorsum and the width of the nasal tip. I very rarely I use spreader grafts in the primary cases because my patients, they don't like to have a wide cartilaginous bridge. Again, it was a trapezoid tip. This is much softer tip. This is the side view, the dynamic views, three-quarter views. Was a kind of bifidity here. This is the other three-quarter views, the side view, and three-quarter views. This is my concept of how to deproject the tip. Was a huge nose by preserving the continuity of the tip cartilages. Of course, here the most common solution is cutting the lateral crust over there, overlapping them, cutting the medial crust, overlapping them, or suturing them. Remember, you are really, in this case, disturbing by these techniques the normal anatomy. We substitute the anatomical continuity with little suture 5-0 or 6-0. My idea is that in this case, you have to work on the septum, on the nasal spine, on all the elements of the tip of let's say of the structural points, anatomical points of the tip, and pushing all them back. So you may keep the anatomical continuity of the tip cartilages. This is the front view again, the brow dome lines, the nasal tip. Again, it was done by transcartilaginous extended. The nasal tip, you see here, the base radix view, the helicopter view, and the side view, which was the view more disturbing for the patient. This young girl, 16 years old girl, didn't go out from home because it was always bullied by her mates, by her school mates. She changed completely the mindset, also due after rhinoplasty. This is the dynamic views, smiling views. Look here, the tip was just tangent to the upper lip. We have created much more light and much more visibility of the upper lip. The three-quarters view, the other three-quarters view, side view, three-quarter view. Much more, again, the supracrural shade here. I like it very much. Of course, if you put grafting here, you lose it. So in this case, I don't like this bulky ala that we see too often in meetings. This is the other three-quarters view. Again, nice girl, Generation Z. She told me, doctor, actually, my tip is fine. What I don't like are these two ridges here, and this, especially on the three-quarters view. I just want this. I don't want anything else. These were her main complaints. Of course, when I take the photos after, when I do the photo analysis and we discuss the simulations, I told her, you are completely right, but I would just do a little refinement of the nasal tip, and I would just 2 millimeters raise up the columella. You may understand that in cases like this, the endonasal approach is much more powerful because you see exactly what you get is exactly what you see. There is not this flap going up and down and where you have to add cartilage to restore the support that you have, let's say, weakened. The pre and post, a little refinement of the nasal tip. Here we could not see the continuity of the, let's say, of the brow dome lines. I have restored the continuity. The continuity is there. Just a little refinements of the nasal tip, the black and white, the base view, base radix view. It was a kind of inverted V over there. You may understand that here you have to use the micrografting here is essential in this part to restore the continuity of the brow dome lines. Again, much better relationship between the width of the bridge and the width of the nasal tip. Just 2 millimeters pushing back the nasal tip. Just 2 millimeters raising the columella. And it makes a huge difference. Releasing the muscles, shortening the nasal spine, giving more space and more volume to the upper lip. 3/4 view, the other side view, straight profile line, exactly as she wanted, and the new 3/4 view. Sometimes we have an uncontoured nose. So in this case, I have to create much more definition in a thick skin. So in these cases, my option is delivery approach. You have to see and to suture the domes. And in this case, I did transdomal and interdomal sutures through a delivery approach. The pre and post, again, take special attention to the scroll area here. You see there is volume, shaving the supratip area, refining the nasal tip, shortening the columella a bit. This is the base view, narrowing the columellar base here and there, better symmetry of the nostrils, nice definition of the nasal tip, the base radix view. This is the side view, dynamic 3/4 side view and the other 3/4 view. Now, twist the nose. Already septoplasty done, still twisted. You may understand that here osteotomies are the key factor in, let's say, in creating a new nose. Well, of course, you have to rebuild the septum here in this part and to correct the settling. Pre and post, again, the new brow dome lines, too much light, less light, recreating the shades on the lateral part. When she's smiling, the base view, the powerful effect of osteotomies, of multiple osteotomies. Here I did three osteotomies on the right side and 2 osteotomies on the left side. Base radix view, side view, and the other side view, 3/4, no more convexity, no more convexity over there. Now, let's go and see to the last case because we have already took too much time. Yeah, this is the other. This is the last case, the nasal tip. You see the position of the nasal tip, and you see that there is let's say, really an aesthetical alteration between the position of the radix here the hump, this kind of settling here in the position of the nasal tip. She was a tall girl, so don't do a small nose in a tall girl. And in this case, in my vision, the problem was the radix area. So I started to think about to correct the radix area. And when you correct the radix area, you can understand what to do at the central part of the nose at the supratip area. Again, recreating the brow dome lines, transcartilaginous approach. You see the relationship between the width of the bridge and the width of the tip. The helicopter view, brow dome lines, more symmetry of the scroll area. This is the side view, no structural grafts, no spreader grafts, no columella strut, just a radix graft over there to raise the nasal in order not to reduce too much the height of the dorsum. Smiling, again, muscles. I work on them in about 3/4 of my cases. The new 3/4 view, the side view again, straight nose, just a little concavity here. And the other 3/4 view. Taking on message. I have two for you. The first one is that after, when you become, let's say, older, and might be you become expert, you understand that you do not sell an operation. And you do not sell a commodity. What you sell is a style. This is my style. This is my style in patients that want a lower dorsum. This is my style. Repositioning all the elements of the contour, smoothening the profile contour. Again, rebuilding, let's say, restoring the position and the length of the nasal tip. But actually, and this is, let's say, my style actually is tailoring surgery on every single patient, taking into account that anatomy and the wishes of that particular patients. And take-home message number 2 is that this is of our team of unique rhinoplasty team is dedicated to you, the juniors. Meetings are different from real life. In real life, if you are a professional, safety is the first thing that you should think about. Safety for your patients and safety for you as a professional. So don't become the slave of one technique, of one approach, and avoid the trap of overdoing, and embrace the high power minimalism. And thank you for staying with me this Sunday afternoon.
Thank you so much, Professor Pietro Palma, for the brilliant presentation. It's I think that the key message from here is building a style. I introduce you as an entrepreneur because I really think that you one of the masters that really based his career and the mentality on style. Building a style is important, and building a style upon a face of somebody is different from just doing surgery and doing rhinoplasty. So that's the key message for the future. I think that if you allow me to do this, this is the main take-home message, is more not only for the key conception and subunits, how to work in different spaces, how to rebuild shapes upon different shapes from the face, and to reach attention to every point, convexity, and tip redefining. So there are a few questions, not so many because we are going out of time, but I think that if anyone is interested, you can go to the unique rhinoplasty and ask for questions directly from the professor. So the first question is, what are the differences between this technique for flattening lateral pleura and doing it with sutures? How to decide?
Well, I don't like the sutures. I have used the Gruber sutures. I've used them, but in my hands, they were not as predictable as this shaving. Sometimes, especially when you have tiny cartilages, you do the sutures and then they break. And then if you have thin skin, the sutures can be visible. So this is just a personal experience. Shaving is much more safer and more efficient than sutures.
The second question is how to access to the subcrural shade.
Transcartilaginous approach. You do an intracartilaginous incision, exactly as I was showing you in the video. When you do the intracartilaginous incision, what do you see? The first thing is the cephalic part of the lower lateral. Then you see the soft tissue, and then you see the caudal margin of the upper laterals. Many times, this lower margin, there is the returning. So in this case, I shave the returning. I never shorten the upper laterals, except in case of long noses, of course. But pretty frequently, I reduce the returning because it is the main responsible of the fullness of the scroll area.
Now the question is, what are the essential and suggestions for the infiltration for endonasal approach?
Mhm. Well, actually, I do not infiltrate. I never infiltrate the dorsum because I want to keep constantly the control of the skin. So, it is important to work with a good anesthetist that will allow you to see what you are doing. But I never infiltrate the dorsum because I want to check the position of the skin, the thickness of the skin. Because in my way, I have to get what I see, and I do not want to create any distortion to the skin. Remember, skin. This is something that you learn after many years of practice. Skin is responsible, in my view, of about 50% of the final result, and we should really take special attention to the nasal skin.
Now the question is, how do I correct the bulky spine?
The bulky spine, well, you access. I don't know which kind of access do you use for the septum. I use the hemitransfixion incision, and then I do the classical pre-maxillary approach. Then you dissect lateral to the nasal spine, and you see the nasal spine in front of you. Then you take a rongeur, and then you, let's say, shorten it, or you can use a 2 millimeters osteotome. And if you want just to, if there is a slight asymmetry, you can use a rasp, a small rasp. So you have 3 tools.
We have time just for one more questions because
Yes.
otherwise we're going to be late. I hope that you don't mind. Please, we have more than 45 questions. I'm very sorry for everyone. Please do refer directly. If you want, you can send us an email and we will try to get to Professor Palma directly. We will refer to him. But this is the last question before closing our remarks. How can I approach to the keystone area through the endoscope?
The keystone area. Well, actually, I don't use the endoscope in a rhinoplasty, but they can be. Of course, we do not have time for this. But when I do, for instance, when there is a big hump, I always do the extramucosal approach. The extramucosal approach, it means that you do exactly what I was showing you when in the endoscopic clip. You do a tunnel below the cartilaginous vault, a continuous tunnel below the cartilaginous vault and the bony vault. So you are going to create these two bridges. Well, using the endoscope here can be quite useful.
So thank you so much. We are perfectly on time with this. Thank you, so Professor, because
You're
of
very
the
welcome.
brilliant presentation. I think that the meaning of all of this, after the introduction of how to do your mentality and how to reshape the thinking to the anatomical part, to the characteristics and the tips and faults for this, it's the whole remark will be based on tailor your procedures. I think that the main part from you now is, and I think that every juniors, I'm very young, that, so I've been a part of the ERS juniors for this, and I'm still thinking about myself as a junior. So because this is what I want you to bring for the future generation, and what you're bringing to them is that being constantly up to date and thinking about new generation and stay up to date, because thinking is mandatory and upgrading is mandatory in a generation where social medias exist. We cannot say this is just a virtual stuff. Those exist, and the fact that you raise the concern in regard to this is mandatory, as in fact is the main point. So if you wanted to improve yourself, think about all this stuff and think about what Pietro Palma just said. Think about your style. So style is essential. Thank you so much for this brilliant presentation. For anyone interested, go to our YouTube pages, Facebook pages. The recording will be for you free as always. Thank you once again, Professor Farber, for your participation in this Sunday, because it's a day off. So you left for us some of your tips and techniques and your time.
Thank you.
Thank you once again.
Thank you.
Thank you
Goodbye.
once again, and I really goodbye to